everyone. I'm Dr. Shin-Young Yim, the Center for Torticollis, a Jew University Hospital, South Korea. In videos from 149 to 152, I discussed the symptoms, causes, and treatment of cervical dystonia. This video is the summary of this. Cervical dystonia is also called spasmodic torticollis. Cervical dystonia is a painful condition in which the neck muscles contract involuntarily, causing the head to twist or turn to one side. Cervical dystonia can also cause your head to tilt forward or backward uncontrollably. This patient shows the chin toward the right shoulder and the right ear toward the right shoulder. Therefore, he has right torticollis and right laterocollis. In some cases, the involuntary muscle contractions associated with cervical dystonia can spread to nearby body areas. The most common locations include the face, jaw, arms, and trunk. Many people with cervical dystonia also experience neck pain that can radiate into the shoulders and arms. The disorder can also cause headaches. A head tremor, a jerking motion, may also occur. Many people experience difficulties in activities of daily living and might avoid interpersonal relationships. The symptoms of cervical dystonia can be exhausting and disabling. Some people experience sensory tricks that sensory stimulation, such as touching the neck or shoulder, can ameliorate cervical dystonia. Some patients often discover some improvement early in the morning, called morning benefits. Many patients experience that stress or excitement may aggravate symptoms of cervical dystonia. The symptoms usually begin gradually. They may get worse over time and then reach a plateau where they don't get substantially worse. Cervical dystonia is a rare disorder with a prevalence of 5 to 20 per 100,000 people. Although it can occur at any age, cervical dystonia most often occurs in middle-aged people. The male-to-female ratio is from 1 to 1.4 to 1 to 2.2, which is relatively common in women. 70 to 90% of cases are in their 30s and 50s. Cause of cervical dystonia. Cervical dystonia occurs due to functional abnormalities in brain regions such as the midbrain or basal ganglia. Most people with cervical dystonia are called idiopathic, where the cause is unknown. Some cervical dystonia is caused by medication blocking dopamine, such as antipsychotics. Some people have a family history of the disorder. Researchers have found gene mutations associated with cervical dystonia in some cases. Cervical dystonia is also sometimes linked to injuries or diseases of the head and neck. However, not all these risk factors result in cervical dystonia. A person with a genetic predisposition to cervical dystonia can develop cervical dystonia when the risk factors are given, such as infection, trauma, certain medications, and stress. In terms of treatment of cervical dystonia, there are non-surgical medical treatments, surgical treatments for cervical dystonia along with physical therapy. There is no cure with the current medication for cervical dystonia. Medical treatment is aimed at alleviating symptoms of cervical dystonia. It is just like antihypertensive or sugar-lowering drugs do for hypertension and diabetes mellitus. One of the most commonly used medicines in cervical dystonia for oral medication is trihexin, a cholinergic agent. Clonazepam, called Rivotril in the brand name, is also used for cervical dystonia. You can use a muscle relaxant, baclofen. These drugs are used together or alone. These pictures show trihexin, Rivotril, and baclofen, respectively. Depression, anxiety, sleep disorder, or pain in the neck and shoulder are common in cervical dystonia. When symptoms are severe to affect daily function, treatment is required. We can use botulinum toxin for the treatment of cervical dystonia. Botulinum toxin is a neurotoxin produced by the bacterium Clostridium botulinum. For muscle contraction, the muscle cells receive signals from the nerve cells. A synaptic cleft like this separates the nerves and muscles. The neurotransmitter acetylcholine is secreted from the nerve terminals and binds muscle cells. Then muscles contract. In cervical dystonia, unwanted, involuntary muscle contraction occurs, causing abnormal head and neck posture. Several proteins, called snare proteins, need to interact with acetylcholine vesicles for the neurotransmitter acetylcholine to release. Botulinum toxin breaks down the snare proteins involved in the secretion of acetylcholine, then muscle contraction cannot occur. Therefore, This helps with the abnormal contraction of cervical dystonia. This is to prevent the secretion of the transmitter acetylcholine. Botulinum toxin treatment for cervical dystonia was first reported in 1985. After that, many researchers reported the therapeutic effects of the botulinum toxin. In 2000, botulinum toxin was approved to treat cervical dystonia in the USA. The success rate of botulinum toxin is about 70%. The average duration of botulinum toxin is about 12 weeks. Around 3 months after injection, the botulinum toxin is no longer left in our body. The symptoms of cervical dystonia can recur. In most cases, repeat injections may be required at 3 to 6 months intervals. Accurate selection of involved muscles in cervical dystonia and injection with ample dose determine the effectiveness of botulinum toxin treatment. Swallowing difficulty. Dysphagia may occur temporarily when botulinum toxin spreads to the esophagus. These side effects, such as dysphagia and weakness, are temporary, and they improve. Let us move on to the surgical treatment of cervical dystonia. Some patients do not respond to oral medications and the botulinum toxin injection. Surgery is considered for this case. Deep brain stimulation and selective peripheral denervation are primarily done in surgical treatment for cervical dystonia. Deep brain stimulation. As the name suggests, deep brain stimulation involves inserting an electrode deep into the basal ganglia of the brainhead and stimulating it. The stimulation of deep brain stimulation is electrical stimulation. Deep brain stimulation improves these disorders by controlling abnormal neural circuits with electrical stimulation. Before deep brain stimulation was introduced, when a patient had severe dyskinesia, a part of the basal ganglia was destroyed with electricity or liquid nitrogen. In deep brain stimulation, electrical stimulation can be turned on or off whenever we want. In addition, the intensity of electrical stimulation can be finely adjusted, so it has the advantage of treating patients according to patients' conditions. A particular device is required for deep brain stimulation. The deep brain stimulation system has an impulse generator that generates electrical stimulation. The system also consists of microelectrodes that stimulate a specific part of the brain and a connection line that connects the impulse generator and the microelectrodes. Impulse generators have software programs to adjust the stimulus intensity and frequency of electrical stimulation and remote controls to turn these impulse generators on and off. Among the basal ganglia, the internal globus pallidus is the most used deep brain structure, and the subthalamic nucleus is also used. The connection line and impulse generators are placed under the skin. The impulse generator uses a battery that usually lasts 3 to 5 years. A battery can be used for a longer time with the recent development of technology. When the battery's life is exhausted, the battery is replaced with the new one. Recently, a wireless battery charging system using radio frequency energy has been introduced. Let us go over the indications for deep brain stimulation. It can be used in patients with cervical dystonia who do not respond to oral medications or botulinum toxin injection therapy. Let us take a look at the surgical procedure of deep brain stimulation. All hair of the patient is shaved on the day of surgery, and a brain MRI is taken with a stereotaxic frame on the head. With the MRI, we can get a coordinate for the target for deep brain stimulation. Coordinates of the internal globus pallidus or subthalamic nucleus can be found. The patient is anesthetized in the operating room once the coordinates are determined. The surgeon makes a hole about 1.5 centimeters in the skull. Through the hole, we insert the microelectrode of the deep brain stimulation into the calculated coordinate of the brain. With electrical stimulation, we select a location that shows optimal signals. Then we insert permanent microelectrodes at the exact location, such as the internal globus pallidus and subthalamic nucleus. In most cases, deep brain stimulation is performed on both left and right sides, once on the right, then on the left. Therefore, 2 surgeries are usually performed. An incision is made in the skin under the clavicle or the armpit, and the impulse generator is embedded under a large muscle called the pectoralis major. Immediately after surgery, the impulse generator is not activated, and the stimulus is usually initially turned on the next day. After the initial programming, an outpatient visit is required for adjustments. And depending on the patient's condition, additional programs may be required. When it is time to replace the battery, you can replace the battery through reoperation or recharge through radiofrequency. A week of hospitalization is required for the operation. After surgery, an outpatient visit is required every few months. Let us take a look at the side effects of deep brain stimulation. Because it is a major surgery, there may be side effects related to the surgery itself. There may be infection and bleeding in the surgical wound. There may be side effects from electrical stimulation. Apathy, hallucinations, hypersexuality, cognitive dysfunction, depression, and euphoria may appear. These side effects can be managed by adjusting the electrical stimulation. In most studies, deep brain stimulation has been reported to have long-term effects. There is a score that evaluates the severity of cervical dystonia, and it is reported that the score of about 23 before the DBS, and the score has been kept at about 16 to 17 points after 10 years of deep brain stimulation. Now, I am going to talk about selective peripheral denervation. Selective peripheral nerve denervation is a surgical method that finds the peripheral nerve that controls the muscle causing cervical dystonia and selectively cuts the peripheral nerve so that the muscle does not contract. For example, if the semispinalis cervicis muscle causes cervical dystonia, selective peripheral denervation selectively cuts and destroys the peripheral nerves that control the semispinalis cervicis muscle. Let us go over the indications for selective peripheral denervation. It can be used in patients with cervical dystonia who do not respond to oral medications or botulinum toxin injection therapy. Let us talk about how to do selective peripheral denervation. Among the muscles causing cervical dystonia, surgeons usually select 2 to 3 muscles that are the most problematic. They selectively cut the peripheral nerves that control these muscles. The muscles most used for selective peripheral denervation are the sternocleidomastoid muscle, splenius capitis, and splenius cervicis. Let's look at the effects of selective peripheral denervation. In most studies, selective peripheral denervation has been reported to have effectiveness. This is a study from the Mayo Clinic. Selective peripheral denervation was performed in 168 patients with cervical dystonia. 58 to 77% of the patients who underwent selective peripheral denervation report that symptoms of cervical dystonia have improved significantly. Among them, 58 to 81% of the patients report that the pain has improved significantly. 5 to 16% reported no effect at all. 7 to 19% of the patients said there was no improvement in pain. Let us look at the side effects of selective peripheral denervation. Reinnervation and recurrence of symptoms occurred in 29% of patients, leading to reoperation in 26%. In 51% of patients, there was a change in the pattern of cervical dystonia after selective peripheral denervation. Furthermore, in 13%, the dystonia progressed to other areas of the body. Despite aggressive surgery with selective peripheral denervation, disease pathophysiology takes over, indicating that selective peripheral denervation remains far from a cure. Today, I presented the summary of the diagnosis and treatment of cervical dystonia. Thank you for watching this video. See you next time.